Okay, picture this. You're in a packed emergency room. Monitors are going off left and right, and a patient's EKG just printed out. You look down, and there it is. An irregular rhythm. Absolutely no distinct P waves. Atrial fibrillation. As a clinician, you immediately know a stroke is a very real, looming threat. But how do you actually objectively quantify that risk right then and there to decide on the best treatment? Let's dive into it.
To put this into perspective, imagine a 68-year-old woman with a history of hypertension and new-onset AFib sitting in your clinic. The golden question is, do you start her on blood thinners? Well, by the end of this quick explainer, you're going to know exactly how to answer that without a second thought. Salam, welcome to A Little Push, 5 Minutes Medical Mnemonics. Today, we're mastering the absolute standard for determining stroke risk.
You know, we used to rely pretty heavily on the older CHA₂DS₂ score, but honestly, it just wasn't comprehensive enough. The modern gold standard is the CHA₂DS₂ VASc score, and the reason it's superior is that it brilliantly identifies the truly low-risk patients by bringing in crucial new factors like vascular disease and sex. It's a real game-changer for precision. So here's the master key. This is the full, high-yield mnemonic table we use to figure out stroke risk in non-valvular atrial fibrillation. We're going to break down every single letter step by step so it permanently sticks in your brain, whether you're out on the wards or sitting for your boards.
Let's start right at the top. The C stands for congestive heart failure. If your patient has any history of congestive heart failure, or specifically a low ejection fraction below 35%, boom, they earn 1 point. Moving on from the heart, we look at systemic pressure. H is for hypertension. This also gets 1 point. But here is the absolutely crucial detail. They get this point even if their blood pressure is completely well controlled on medication right now. That foundational history of hypertension is what we care about for their baseline risk. Now, age is where things start getting heavily weighted. Pay super close attention here. A2 is for age. See that little subscript 2? That means it's a heavy hitter. If your patient is 75 years of age or older, they get 2 points, not 1. Advanced age is just a massive driver of stroke risk in AFib.
Next up, D for diabetes mellitus. The sheer presence of diabetes adds a single point to the score, mainly because those metabolic changes naturally bump up their vascular risk.
All right, here is our second heavy hitter. You see that second subscript 2? S2 stands for a prior history of stroke, a transient ischemic attack, or any thromboembolism. Look, if they've already had an event, their risk of having another one is incredibly high, so this automatically skyrockets their score by 2 points.
Let's look at the newer additions that make this modern version so pinpoint accurate. V is for vascular disease. This specifically covers things like a prior myocardial infarction, peripheral arterial disease, or aortic plaque. Any one of those history items? That's 1 point.
You'll notice we have another A here, but this one is for the age category of 65 to 74 years. Contrast this with our earlier A2. If they fall into this slightly younger middle bracket, they just receive 1 point.
And finally, to round the whole thing out, S stands for sex category. In this specific clinical context, being female inherently carries a slightly higher stroke risk, so it counts as 1 point in the overall calculation. Okay, so you've tallied up all the points. What do you actually do with that number? Let's talk management thresholds. A score of 0 means low risk. Generally, no antithrombotic therapy is needed at all. A score of 1 puts them at moderate risk, meaning you might consider aspirin or oral anticoagulation based on their specific clinical picture and personal preference. But a score of 2 or higher? That's high risk, and oral anticoagulation is strongly recommended.
For those high-risk patients scoring 2 or more, what are our actual pharmacological tools? Well, your options include the classic warfarin, as well as the newer oral anticoagulants, often called NOACs or DOACs, which include dabigatran, rivaroxaban, apixaban, and edoxaban.
Now, stop and listen, because here is a massively testable caveat you absolutely have to know. Think back to that female sex point. For women under 65 years old who have 0 other risk factors, that 1 point for sex alone is not enough to mandate anticoagulation. In the real world, their effective score is just considered a 0.
And this brings us to the most critical exception to the entire system. I need to be totally clear on this. This scoring system applies exclusively to non-valvular atrial fibrillation. If your patient has AFib due to mitral stenosis, or if they have a mechanical heart valve, do not even calculate this score. They are at such high risk that they must be treated with warfarin, completely regardless of what their CHA₂DS₂ VASc score would be. That is an absolute rule.
All right, let's see how well you've mastered this with a rapid review quiz. Here's the scenario. A 76-year-old male with diabetes and non-valvular AFib. What is his CHA₂DS₂ VASc score? I'll give you a few seconds to think.
The answer is 3. Remember, age 75 or older is a heavy hitter, so that's 2 points right there. And his diabetes adds another point. 2 + 1 is 3, firmly placing him in the high-risk category that needs anticoagulation.
Excellent! Let's try one more to test that tricky caveat we talked about. A 60-year-old female with non-valvular AFib and absolutely no other medical history. Does she need a NOAC? Take a few seconds. No way! While she technically gets 1 point for the female sex category, she's under 65 with absolutely no other risk factors. Her effective score is 0, meaning her risk is low and she doesn't hit the threshold for a blood thinner.
Knowing this mnemonic inside and out is literally going to save you on the wards and help you crush your boards. It's all about taking incredibly complex medical decisions and making them structured, simple, and actionable. So what do you think? As medical data gets even more precise, will AI eventually calculate these risks for us, or will clinical intuition and solid scoring systems like this always remain king? If you found this explainer helpful, make sure to subscribe to A Little Push for more high-yield medical mastery. Keep studying hard and trust your training. Until next time, so long.